Hi guys, I'm Dr. Sunil Sharma. Today's topic is otosclerosis. Today's topic is otosclerosis. The term coined by Adam Politzer in 1901. This term otosclerosis coined by Adam Politzer, who researches between 1893 to 901 on otosclerosis. Now, what is definition of otosclerosis? Definition: it is localized hereditary bone metabolism disorder of otic capsule enchondral bone leading to disordered resorption and bone remodeling. So, otosclerosis is localized hereditary metabolism disorder of otic capsule enchondral bone. Enchondral bone, that is, which bone remain unossified, leading to disordered resorption and bone remodeling. So initially there is bone resorption by osteoclast. Followed by neobone formation by osteoblast. So in this process, the bone resorption is called spongiotic bone. During this process, bone is spongiotic. That's why it is also called spongiosclerosis. And this is sclerotic phase, and this bone is very dense. So this is definition of otosclerosis. Otosclerosis is more common in female than male. Ratio is 2:1 because of hormonal and COL1A1 gene. Because of hormonal, it's more common in pregnancy. Age is common between 15 to 45 years of age. Okay, it's more common in white and Indians. Then Africans and Negroes. So this is more common in white and Indians than Negroes and Africans. So it's common in female. So age is about childbearing is between 15 to 45 years of the age. Ratio is 2:1. It may be related with COL1A genes, which is more common, or another gene is RELFM, which is more found in the females. So this may be a cause, hormonal plus gene mutation, and pregnancy leading is to 2:1 ratio. Age is 15 to 45 years of age. More common in white Indians than the Negroes in Africans. Now, what is etiopathogenesis? Etiopathogenesis. In this, if you say pentagon like this, first cause is genetic factor. Genetic factor. Second one is viral factor. It is multifactorial disease, so viral factor. Third one may be autoimmune. Autoimmune factor. Fourth one is cytokines, viral factor, autoimmune, and fifth one is hormonal factors. In this, you can see etiopathogenesis. Maybe it may be genetic factor, viral factor, autoimmune, cytokine induced, or hormonal. So there may be these causes. It is mostly autosomal dominance, 50% is case with variable penetration. Genetic, and 50% cases of otosclerosis is genetic and mostly autosomal dominant with 50% variable penetrance. Gene, a lot of gene has been found in otosclerosis. Otosclerotic gene 1 to 10 has been identified. Otosclerotic gene 1 to 10 identified. Then gene in osteogenesis imperfecta COL1A1 gene has been identified. Then RAS gene, RAS4 renin, aldosterone, angiotensin system has been identified. So these are the common genes which lead to genetic form of otosclerosis. Now viral factor. Viral mainly measles. Measles viral, which is RNA virus, has been isolated a lot of temporal bone dissection of otosclerotic patients. There a lot of IgG antibody found in otosclerotic bone. Then RNA antigen also found otosclerosis genes, and more IgG bodies in measles protein particle. So this suggests a viral factor in this otosclerotic genes. Now autoimmunity, a lot of antibodies found over collagen type 2. So and it's having some autoimmune factor also, like antibody, a lot of antibody found collagen type 2 genes. Cytokines mainly. Cytokine, if you see bone morphogenic protein, and tumor growth factor beta 1. There has been there are two cytokines. One is bone morphogenic protein and tumor growth factor beta 1 has been found isolated in this otosclerosis, which having more role in otosclerosis. And two more cytokines recently identified. One is osteoprotogerin osteoprotogerent and rank L. Rank L is receptor activation nuclear KB ligand. These two cytokines recently identified in otosclerosis. This inhibits the osteoclastic maturation, and this is opposite of this. This enhances the osteoclastic maturation or bone resorption. So this is osteoprotogerent, Rankel, bone morphogenetic protein, tumor growth factor V1. These are the cytokines related to otosclerosis. Then hormonal, mainly angiotensin, type 2 hormone, and estrogen. These are the main hormonal factor for etiopathogenesis of otosclerosis. So in revision, we can say genetic factor, mainly autosomal dominant, viral factor, mainly measles, particle, RNA particle, autoimmunity, maybe RAS and antibody against collagens, and cytokines, mainly bone morphogenic protein and tumor growth factor beta 1, osteoprotogerent, Rankel 1, and this is hormonal, mainly estrogen and angiotensin type 2 has been related to otosclerosis. These factors leads to activation of osteoclast, which lead to bone resorption and cellular and vascular inflammation. The osteoclast activity leading to bone resorption by cellular and vascular inflammation in the otic capsule. This lead to spongiotic cavities or bone formation, loose bones. So this lead to spongiotic cavity and loose bone formation in the otic capsule. After this, the phase of new bone formation and remodeling lead by osteoblasts. Okay, the new bone formation lead by osteoblasts, this having the sclerotic phase. In this phase, the spongiotic phase, if you stain this by He stain, hematoxylin eosin stain, there will be blue sign, that is temporal bone look like blue mantle. This bone is look like blue mantle. In this phase, the bone is dense. If you stain with hematoxylin eosin stain, it will be red mantle or pink. So this is also called blue mantle sign. Okay, blue mantle sign found in the otosclerotic spongiotic form. MCQ. Okay. In this phase also, you can find this is active phase. Active phase. Okay. If you see the tympanic membrane, through otoscopy in 10% cases, there may be flamingo pink color over the promontory due to active vascularity and cellularity. This called is Schwartz sign. This is called Schwartz sign. It's found in the 10% of cases, because if we see the patient at maturation phase, there is this what happens in this process. In this normal lamellar bone replaced by loose woven bone. This bone, laminar bone, replaced by loose woven bone, later on by disordered new bone formation. So this loose bone leading to high cellularity and vascularity, so as Schwartz sign. Now, what is the type of otosclerosis? Types. There are two types of otosclerosis. One is clinical otosclerosis, OTS. Second one is histological otosclerosis. If we see histologically after death, about 8% of cases, 8% of cases of temporal bone examination, this otosclerosis is present. Otosclerosis foci are present clinical, histologically, but no clinical loss of conductive hearing loss or sensory hearing loss in these patients. But in clinical otosclerosis, you can see clinically conductive hearing loss, progressive conductive hearing loss, or maybe sensory hearing loss. Again, that's why it's divided into two types. One is fenestral otosclerosis. Second one is retrofenestral, or you can say cochlear otosclerosis. Clinical otosclerosis, if conductive hearing loss, it is fenestral otosclerosis. If it is sensory hearing, it may be cochlear otosclerosis. In this fenestral, mainly anterior part of the crura of the footplate or footplate area is involved. That is called Fissula ante fenestral. Fenestral means oval window area is involved. So most common area in 96% of cases, this area is fissula ante fenestrum involved. 96% of cases, followed by round window area in 26% of cases, followed by cochlear apex in 16% of cases, then posterior fenestral, yani posterior crural area is involved. So this is the frequency in fenestral otosclerosis. Most common area involved is fissula ante fenestrum, that is anterior part of oval window where anterior crura is situated of stapes, then round window, and then cochlear apex, then posterior fenestral crura is involved, that is posterior part of footplate is involved. There may be involvement of internal auditory canal thereafter, or cochlear involvement is also there. So cochlear apex 16% of cases. And the retrofenestral is cochlear otosclerosis. There is cochlear endosteal layer is involved. So this cover the whole cochlea, promontory to apex, basal turn to apex. Then it is called fenestral cochlea. There is sensory hearing loss or mixed hearing loss is there. So otosclerosis divided into clinical otosclerosis. We can see clinically in moving patients to us in OPD, and histological otosclerosis. This 8% when we dissect the temporal, we will find histologically there was otosclerosis but no clinical sign of otosclerosis, no hearing loss. Now diagnosis. Diagnosis. If you see clinically, by history, patient between 15 to 45 years of age come to our OPD with bilateral progressive conductive hearing loss. This patient typically come to us with bilateral progressive conductive hearing loss, age about 15 to 45 years of age, mostly female. It may be pregnancy, during pregnancy, or not with don't have any pregnancy also. So this is the typical history. If on otoscopy the tympanic membrane is normal in 90% of cases. In otosclerosis cases, tympanic membrane is normal in 90% of cases, but in 10% of cases it may show active foci over promontory that look like flamingo, pink color of promontory. This is called Schwarzschild. Okay, in 10% cases and 90% cases of otosclerosis there is normal tympanic drum. If we do pure tone audiometry with impedance, these patients will have low frequency conductive hearing loss. Low frequency conductive hearing loss with AS type of curve with decreased bone depth over 2000 Hz due to Characterized notch and absent stapedial reflex, biphasic absent of stapedial reflex. So these patients typically have a low frequency conductive hearing loss. You can say most common cause of adult acquired conductive hearing loss, this is otosclerosis. So again MCQ, most common cause of adult conductive hearing loss, acquired conductive hearing loss, this otosclerosis. In PTR impedance you find classically low frequency conductive hearing loss, AS curve with bone depth over 2000 Hz, this is also called Characterized notch, and absent stapedial reflex, biphasic absent of reflex. So this is classical patient of otosclerosis. If you see audiogram of these type of patient, dB loss. If you see these type of the patient, the bone conduction is over 500 or 1000 Hz, 2000 Hz and 4000 Hz. So dip is, if it is this bone conduction, so there will be dip at 2000 Hz. This is called Characterized nose. Typical patient come with Characterized nose. This is because of acoustic and ossicular coupling of maximum frequency occur at this bone conduction. That's why Characterized nose is found. That is also called Characterized sign. It is called Characterized effect. If you see bone conduction, this is tympanic membrane. Malleus incus and this is stapes. And if you see bone conduction may occur by direct temporal bone through direct temporal bone leading to bone conduction through ossicular chain by tympanic membrane and through temporal bone to the ossicles. So these are the three ways. This effect is more on Characterized effect. That's why leading to Characterized nose at 2000 Hz. In 2 to 10% of cases, 2 to 10% of cases, there is accent loss or mixed hearing loss. It's found in cochlear type of otosclerosis. So these patients are not a candidate of stapedectomy or stapedectomy because these patients already having accent loss. In this case, cochlear type, some cases you can see this is scala tympani, this is scala media, this is scala vestibuli. This is scala vestibuli, scala media and scala tympani. In scala vestibule, or this is Scarpa's or spiral ligament. This is Scarpa's ganglia and this is spiral ligament. Spiral ligament. In this case of cochlear otosclerosis, there is deposition of hyaline. Deposition of iron due to reactive toxic cytokines of otosclerotic foci. This is bone. If you see these is the spiral ligament, these are the otosclerotic foci. In cochlear type of otosclerosis, the spiral ligament having deposition of hyaline. This is hyaline deposition. So this is more common in cochlear type of otosclerosis. Now, clinical otosclerosis, again, if you see stapedial fenestral otosclerosis. Fenestral otosclerosis, again, divided into 5 types. So, this is stapes. This divided into 5 types. Anterior foci. Anterior foci, also fissula anti-fenestram. This is most common site. If anterior footplate is involved, this is called area of fissula anti-fenestram. This area is found in 97% of the cases. So This area initiate the otosclerosis and conductive type of fenestral type of otosclerosis. Second type is posterior area, posterior foci. In some cases, the posterior crura area is involved in otosclerosis. Third one is circumferential. If this entire footplate annular ligament is involved, this circumferential involvement is there, then it is called circumferential involvement. Fourth one is viscid type. Viscid type. If this area deposition of viscid except annular ligament occur like this. This annular ligament is not involved in this viscid type, only deposition of an oval window, this footplate area. This is like this obliterated, this viscid type, deposition of new bone over, this is called viscid type. If it is obliterative, then it is annular ligament also involved. So this whole annular ligament also involved, then this is obliterative type of otosclerosis. These viscid type and obliterative type are difficult to treat because we have to drill the footplate area before putting the piston or doing staphylotomy. So this is fenestral type of otosclerosis. Now DD, differential diagnosis. Any patient with normal tympanic drum with conductive hearing loss, adult patient, come to us as DD of otosclerosis. It may be trauma with ossicular discontinuity. It may be superior canal dehiscence syndrome. Okay. Superior semicircular canal dehiscence syndrome. It may be CSOM with tympanosclerosis. It may be congenital malleus fixation. So these are the common DDs. It may be traumatic discontinuity of ossicles, it may be superior semicircular canal dehiscence syndrome, it may be CSOM or tympanosclerosis, it may be congenital malleus fixation. These are the common DDs of this otosclerosis. Now, according to diagnosis, what is required? Management. Diagnosis, if you see, I will recommend PTA. Impedance is not necessary, but we can have impedance also. Okay, you will see there is conductive hearing loss and diff over 2000 Hz. This is classical and Piotron audiometry of otosclerosis cases, and low frequency hearing loss, conductive type of hearing loss. Second one is you can have imaging. Mainly CT scan is preferable over MRI. CT scan, if you see CT scan of this otosclerotic patient, the Fanny and Simon in 2005 stays on CT scan finding the otosclerosis in, if you see, these are stages, 3 stages, stage 1, stage 2 and stage 3. Wife Simons and Fanny and Simon on CT scan imaging divided the otosclerosis in 3 stages. 1 stage, 2 and 3rd. Stage 1 is if there is hypodense area, hypodense lucency over oval window, then it is called fenestral. Fenestral type of otosclerosis. Any foci, hypodense area and CT scan, it is during the spongiotic stage, then it is stage 1. And stage 2, if this hypodense area involving the promontory or cochlea, if basal turn is involved, then it is stage 1A, 2A, basal turn involvement. It may involve fenestral or not, plus minus fenestral. If it is involved the middle turn of cochlea, then it is called type 2B. The hypodense area over basal turn and hypodense lucency over middle turn, and if apical or middle turn, lateral aspect of middle turn and apical turn involved, then it is stage 2nd C. And third is whole cochlea, whole temporal bone or cochlea is involved, then it is stage 3. There you can find the double ring sign. This is advanced stage. So Fanny and Simon worked on 2005 over CT scan finding of otosclerosis. They divided this CT scan finding into 3 stages. Stage 1, this over window is involved, that is called Fenestral Otosclerosis. Hypodense lucency, you can see lucency, this loose area of bony foci over the over window. Then stage 2, if cochlea is involved, lateral aspect of cochlea, not whole cochlea, which we are not talking about the medial aspect which is related to internal auditory meatus. So lateral aspect is basal turn is involved, type 1A. If middle turn is involved, type 2B, and apical, lateral aspect of apical turn of cochlea is involved, then it is 2nd C, in which this fenestral is involvement is there, or it may not be there. The stage 3, the whole cochlea from medial aspect to lateral aspect, from superior to inferior aspect is involved, then it is having double ring sign on CT scan, then it is called stage 3. Then one definition is cavitating otosclerosis. One term is cavitating otosclerosis. This spongiotic stage, the active stage of otosclerosis, if you see, this is vestibule, and this is stapes, this is vestibule, and this vestibule having cavity type formation due to active process of disease, then it is called cavitating otosclerosis. In this type, if you are putting the piston over footplate, there will be no correction of conductive hearing loss because of this cavity, and this large cavity may lead to perilymph leak or endolymphatic hydroformation because of large cavity. So this is large cavitation of vestibule due to active form of otosclerosis leading to cavitating otosclerosis. This is new term, you can see cavitating otosclerosis. Now management. Management of this patient, otosclerosis. Now first management is, if active form is there, active form leading SN loss is there, you have to manage by sodium fluoride or biphosphonate. They decrease the new bone formation or bone remodeling. Sodium fluoride can be given. Its only effective in the active phase of otosclerosis, both biphosphonate and sodium fluoride. You can give sodium fluoride 20 to 60 milligram per day up to 2 years. In active form, you will find active form by PTA. There will be mixed hearing loss or sensory or active disease on CT scan. You can see, you can give 20 to 60 milligram per day. Up to 2 years, you have to give sodium fluoride therapy. And biphosphonate, you give antidronate or alendronate, biphosphonate, and it is just like Paget disease and osteoporosis. We are giving that, and we can give in this active form of otosclerosis also. Now, surgical management. Surgical management. First, who are the surgical candidates? First, any patient with bilateral progressive conductive loss more than 20 dB loss. There should be 20 dB loss. Minimum 20 dB loss is required for doing surgery of otosclerosis, and there should not be no active disease. No active disease like CSOM, otitis externa, there should not be any active disease. Drum should be normal. Drum of tympanic membrane normal. If suppose there is perforation, we can in first stage we do tympanoplasty, or there is canal is very narrow. We can go canalplasty in first stage. Later on we can proceed that stapedectomy or stapedectomy after doing tympanoplasty. So there should be conductive hearing loss, active hearing, and there is speech discrimination score should be more than 60%. Or you can say word recognition score should be more than 60%. So this is the minimum criteria for doing otosclerotic surgery. Now, there is one term. Now, first we will tell about management. You can give hearing aid. A patient having mixed or sensory hearing loss, you can give hearing aid. Second one, you can do cochlear implant. I will tell you whom patient we require cochlear implant, and you can have new therapy, that is DCAS. This is direct cochlear, direct acoustic cochlear stimulator devices, DACS. These are the new therapies, new devices that are direct acoustic cochlear stimulator devices. These devices, if this is the STPs, these devices having the vibratory component when we fix over the ossicular prosthesis. Ossicular prosthesis with middle ear implants. So, what are the devices? These are the direct acoustic cochlear stimulator devices which formed by the ossicular prosthesis plus middle ear implant, in which you can say middle ear implant is over there, over the ossicular prosthesis. If you can say we are replacing doing, so this is the footplate and this is the direct acoustic cochlear stimulator device. This device is like this is the piston. So there is vibratory component is here. So this is middle ear implants. Middle ear implant with this piston is called direct acoustic cochlear stimulator device. This is mainly used in far advanced otosclerosis. I will tell you what is far advanced otosclerosis. So these are the management and cochlear implant, and this is microscopic stapedicotomy or stapedectomy. So these are the surgical managements. You can give hearing aids, cochlear implant, DACS, direct acoustic cochlear stimulator devices, which device made by the ossicular prosthesis with middle ear implant. And you can have microscopic stapedectomy, or fifth one is endoscopic. Recently we are doing endoscopic stapedectomy. So these are the 4 surgical management: cochlear implant, direct acoustic cochlear stimulation, and this microscopic or endoscopic stapedectomy or stapedectomy. Now, what is far advanced otosclerosis? What is far advanced otosclerosis? What is far advanced otosclerosis? If otosclerosis patient having sensory hearing loss or mixed hearing loss, if bone conduction or air conduction gap is more than 65 dB, SN loss or gap should be 60 dB. If airborne gap is more than 60 dB or sensory hearing loss, airborne gap. If what is for SN loss or mixed hearing loss? If it is more than 60 dB and if airborne gap more than 60 decibel or air conduction, you can't find bone conduction in above 85 decibels. So air conduction patient which is bone conduction is not recognized above 85 dB by audiometry, that's why air conduction more than 65 dB is called far advanced otosclerosis. This term given by Hausler NCE in 1961. So what is far advanced otosclerosis? If advanced otosclerosis leading to bone conduction, airborne gap more than 60 decibel with SN or mixed hearing loss more than 65 decibel, audiometry can show air conduction more than 85 decibel. So these are the cases of far advanced otosclerosis. How to manage far advanced otosclerosis? There are 3 ways to manage this far advanced otosclerosis. You can manage by stapedicotomy plus hearing aid. In this case, far advanced, you do first stapedectomy with piston plus you add hearing aids. Second, you can give DACS, direct acoustic cochlear stimulation devices. You can give that, already I told you about this. Direct cochlear stimulation device having ossicular prosthesis with vibratory component in this. You can say middle ear implant with ossicular prosthesis called direct acoustic cochlear stimulation device, or you can do cochlear implant. In these cases, so far advanced otosclerosis can be managed by stapedectomy with hearing aid, direct acoustic cochlear stimulation devices, or cochlear implant itself. So these are the management of far advanced otosclerosis. Now, how to do stapedectomy? So most common management of fenestral type of otosclerosis is stapedicotomy plus ossicular prosthesis. Initially, we have started that Adam, Politzer and all scientists started stapedectomy. Stapedectomy, they remove the whole stapes and put the vein graft over which they push the piston. Now this is more recently, since last 20 years or more, we are doing stapedectomy with ossicular prosthesis. What we do, this is the footplate, this is facial nerve. We are removing the stapes superstructures. We are removing the stapes superstructure, we left the footplate, and we are doing control hole. It is called stapedectomy, and we are putting piston over it. This is incus, this is medius. So we are putting piston over the stapedectomy, control hole over the footplate, then it is called stapedectomy. These having more higher frequency gain, this having low frequency gain, and there are more chances of complication like SN loss is in the stapedectomy. Then stapedectomy is having less chance of SN loss and less chance of more chance of getting higher frequency loss. It doesn't matter if your piston depth going in vestibule less than 0.5 mm, you can put piston anywhere on the foot plate, but most commonly you have to do central or inferior third. You have to do central stapedectomy. You have to make hole over the central part of the footplate, or you can have hole over inferior 1/3 of the footplate. This hole should be centrally located, or maybe here, inferiorly located, inferior 1/3. So this is the safe zone because saccule is a more anterior side. So that's why we are doing an inferior or central stapedectomy. This hole in the footplate. So it doesn't matter if your depth is less than 0.5 mm. You can have anywhere. You can do anywhere stapedectomy and put piston, but more location central or inferior. And most common we are doing 0.5 mm or 0.4 mm. We are using these type of the piston. It doesn't matter weight, whatever it is, you have to properly, accurately measure the length by measuring the pipe or piston itself, by putting you can see piston size. You first measure the depth by putting piston over the footplate, and you can measure the length accurately. So accurate measurement of length is compulsory, and accurate stapedectomy. This control hole should be accurately designed without any traumatizing or dislocation of the footplate, so without leading floating footplate. So accurate size should be there. You have to measure the accurate size of stapes piston. It doesn't matter you are doing control hole by perforator, laser or any other device. Okay, you can have this hole by drill, laser or perforator, but it should be control hole. Now how to do stapedectomy? Step of stapedectomy. Stapedectomy, you have to, there may be permeatal approach, retroauricular approach, or it may be your preauricular or any type of approach, but most commonly is transcanal. We are doing transcanal or permeatal approach. permeatal approach. We are lifting if this tympanometer flap from 12 o'clock to 6 o'clock position, about 6 mm lateral to the drum, and we are elevating the posterior half of the tympanic drum. The exposure should be, you can see the facial nerve above, you can see malleus anteriorly, you can see the posterior part of 6 mm part of tympanic bone or tympanic canal, and inferior you can see the round window. This should be exposure. If we expose facial nerve, malleus or inferiorly round window, and we have to drill this bony head. You can drill by this bony head to see the stapes bone properly. You can do by drilling, you can do by chisel or hammer this bone, or you can curate, you can do by curate this bone. So this bone exposure is must to see the facial nerve and footplate area. So by first you have to, if we are doing transmeatal, most of the cases we are doing transmeatal, so you have to do first tympanic membrane, tympanometer flap elevation. Tympanic flap elevation should be anteriorly you can see malleus, and superiorly you can see facial canal, inferiorly round window, and posteriorly this bony end. You have to remove this bony end, then bony hang removal. So you have to remove this bony end. After that you have to check stapes fixation. This is the gold standard test intraoperatively to diagnose the otosclerosis. If we are checking stapes fixation, first you have to check prior dislocation of IS joint. So you can see there will be no mobility. But gold standard, you have to dislocate the inco-stupidal joint and you have to check the mobility. This best mobility of stapes you can check in after dislocating the inco-stupidal joint. You can find this congenital malleus fixation or malleolar ligament ankylosis by dislocating this, or stapes fixation. So gold standard test is intraoperative diagnosis of stapes fixation. You can see in endoscopic or microscopic examination. After finding this, your diagnosis confirm this is stapes fixation. Then you have to measurement of accurate piston size. Okay. Then you have to remove this stapedial tendon. First you have to cut the stapedial tendon. After cutting stapedial tendon, you have to cut this posterior crura by drilling or manual fracture. You have to fracture anteroinferiorly, this malleus inferiorly mainly. Anterior crura is very fragile, this breakdown. So you have to drill this or this posterior crura or stapedial tendon, and after removing the stapes, you have to put piston. You are doing control, measuring the piston size, and after that you have to stapedial. Stapes superstructure removal by doing cutting of stapedial tendon and this, and then you may need control load. Control by perforator, laser or any drill. So you have to do 0.4 to 0.5 mm hole over the footplate, mainly central or inferior location. After doing this, you again measure the piston size and you put piston on incus to stapes. So this is step of transmeter stepotomy. I have done about 50 cases or more and there is no SN loss, but there is consent should be there about consent. You have to take consent for dead ear or SN loss in 1% of cases of stepotomy. You have to take consent of facial nerve palsy, that is temporary, most of the cases due to infiltration. Most of the cases I am doing general anesthesia because it's safe. Doing any stapesial work, if patient arose and suddenly react, then it's difficult to handle local anesthesia. So better to keep patient and take patient in general anesthesia. I am taking 90% of cases in general anesthesia. Take consent of dead ear, SL loss, failure of surgery like conductive hearing loss may be continued, same. So granulation formation over stapes and there may be vertigo also. So you have to take consent about this. What is the complication of stape surgery? The complications. Complication of stape surgery mainly conductive hearing loss may be continued because dislocation of piston or malposition of piston may be there. There may be SN loss. The continuation of SN loss, it may be because more common is stapedectomy. The SN loss is more common is stapedectomy then stapedectomy. More common revision cases then first cases. More common revision cases. More common in less cases. So this SN loss is common. Third one, vertigo. Vertigo may be due to of reactive labyrinthitis, suppurative labyrinthitis, or due to endolymphatic hydroformation due to continuous friction of saccule by the piston itself. There may be perilymphatic fissula may be there. There may be, you have to repair the perilymphatic fistula immediately, you can put vein graft. 5. There may be reparative granuloma formation over the stapes. If reparative granuloma formation, most of the cases we can manage by steroids, conservative approach. So these are the complications of this, and there may be taste loss of altered sense, altered taste sensation due to chorda tympani damage during the stape surgery, or stretching of chorda tympani, and there may be cholesteatoma formation if or drum rupture due to flap elevation. So what are the steps? First you have to, during step you have to elevate the tympanometer flap from 12 to 6 o'clock position, 6 mm lateral to the drum. Then elevation of this, you have to remove the bony head to expose the stapes superstructure or footplate. Exposure should be facial nerve, malleus anteriorly, posteriorly this chorda tympani area or this otic area, and inferiorly round window should be exposed. After removing the bony head, you may do control over before removing the stape superstructure, that is called reverse stepotomy, or you may cut first stapes tendon, then posterior corona, remove the stape superstructure, then do the control over. This is called normal stepotomy, and we have to measure the piston before putting the piston over the hole. You may do the stepotomy by perforator, laser, or drill. And after measuring the length of accurate piston, you have to put piston, and after fixing the piston you just close the reposite the PM flap. So this is all about otosclerosis. Thank you so much.